Welcome, everyone. This is Denise Solzbach. I am the director of the National Center, the Institute for Innovation and Implementation at the School of Social Work at the University of Maryland. And I am standing in for Liz Manley today, who's on a very well-deserved vacation. So thanks for joining us. Let's introduce our speakers. Gary, can I have the next slide, please? So our panelists today are Suzanne Fields. She is a senior advisor for healthcare finance and policy at the Institute with us. Hazelyn Pilgrim is back with us again this month. Welcome back, Hazelyn. She's the executive director of the Family Support Organization of Essex County in New Jersey. And our third panelist is Melissa Schobert. She is a lead policy analyst at the Institute with Suzanne and I. So welcome, everyone. Let's take a look at the learning objectives. So today we're going to have a different format. There's going to be, due to the rich content of really, let's own it, financing. We're going to have more slides today than normal. So it is going to be heavy slides. We are going to have the opportunity for question and answers at the end. So please populate that chat box as we go along. I'll queue them up and I'll help us in a discussion at the end based upon your questions. But today we're going to learn about improving our understanding of state, federal, and other sources of revenue for mobile response and stabilization, describing financing mechanisms, their structure, challenges, and opportunities associated with each. And we're going to really learn about which questions to ask when we're developing those systems, from budgets, strategic planning, financial mapping, and really how do we know what to do in order to promote long-term sustainability. So with that, we're going to, as always, open this up with the family lens and the family perspective. So Hazelyn, please take it away.
Okay.
Well, next slide, please, Gary.
Good afternoon, everyone. So great to be back with you all. I wanted to just share a little bit from a family perspective, why this is an important topic. You know, traditionally, when we talk about youth and family voice, we talk about it in the context of how the services are being delivered, and maybe even evaluating what people's experiences are and what are their thoughts around what's working and what's not. But quite often we may not think of family voice and youth voice as being an essential component when we talk about the financing aspects of the systems of care. But in fact, if we've learned anything in the last couple of years through the experiences of COVID-19, that's an ideal place for youth and family voice to be heard, not only in the planning and evaluation of services and how they're delivered, but actually around the issues of financing and sustainability. What we learned from our experience here in the last couple of years in New Jersey is that it was the partnership between providers and the youth and family voice that played a significant role in some of the outcomes that we were able to achieve as it related to funding, as it related to expanding the resources that were available to support critical needs. And we actually saw the restoration of funding that had been cut because families got involved and partnered with providers. So what we learned is also that when we think about peer support, education, and advocacy, there's a place for systemic advocacy as it relates to financing. So I'm excited about today's conversation, and we'll be talking a little bit further about some of the strategies that we can use to further engage families and youth in conversations that can result in systemic change when it comes to financing delivery systems. So I'm going to turn it over to our next speaker, Suzanne.
Thank you very much, Hazelyn. I appreciate that, and welcome everyone. Melissa and I are going to be talking through various ways to kind of operationalize financing and really kind of build a sustainable approach to financing mobile response and stabilization services. I think first to set some ground and make sure we're all thinking about it in similar ways, we wanted to introduce this graphic. Today, when we're talking about MRSS, we're talking about the continuum in its entirety and what are the various ways to fund all aspects of an MRSS continuum. That continuum includes multiple things that you all have been learning about and dialoguing about and exchanging about, both that crisis prevention component, the ability to have that call triage or a call center component, thinking through a response that can mobilize to the community, building in peer family supports into that approach, and then certainly thinking about stabilization, whether that is, both as part of a mobile response service, but also linkages to other important services in a community. So again, we wanted to level set today to introduce that we're talking about all aspects of MRSS continuum. Next slide, please.
Hello, and to pick up where Suzanne left off from the continuum slide, part of what we're thinking about today certainly is 988 implementation and how it connects to and can support the provision of mobile crisis services to children and families. So as we're talking about financing today, we're going to be encouraging you, states, localities, advocates to be thinking about the ways in which the infrastructure that you are purchasing or designing and the technology as part of that infrastructure is customized for children, youth, and families. So how is it responsive to the unique needs of those individuals and populations? How is it connecting to your care pathway, to your existing trusted community partners and providers? How are you providing appropriate, accessible training and coaching for your workforce? So that's folks who are designing the technology and infrastructure, folks who are answering the crisis call line. How are you developing that training in a way that respects and sustains your workforce? How are you engaging your important partners, your families and youth advocates, your Medicaid partners, your other state agency partners, your local partners, your law enforcement, and other partners as appropriate to ensure that 988 responses are routed appropriately, are responsive to the needs of those individuals and communities? How are you thinking about creating feedback loops to determine outcomes are appropriate and desired by children and families and also by your system payers, which include, of course, data and outcomes? Next slide, please.
Here we wanted to provide a snapshot for you, kind of a national picture of what is current as of April. There have been a couple of changes since then, kind of specific to 988 legislation. This map shows you where states have enacted specific legislation only for 988. We have a host of other states that are doing activities within kind of other kind of amendments to other budgetary processes. But here what we're highlighting is where there's been something kind of specific and codified to 988. The 988 legislation kind of allowed two things to happen, right? It created the national number that, we're talking about, but also allowed states to levy a fee to support the use of the 988 line. And so we have states in various stages of kind of looking at enacting 988 within their own state. We have some states that are engaging in studies, kind of examining the ability to do 988, specifically also looking at it related to their existing 911 services. Then we have other states that have, and those are the light blue states, right? Where they're doing studies, they're examining it, they're planning to do something specific. Then we move into states that are blue that have enacted specific legislation kind of to the 988, but the fee component or state general revenue may or may not have been associated with what they're doing. And then finally, those states that are marked in green have levied a specific fee to commercial mobile services in order to generate a revenue for this. We also have states, as I mentioned, that are looking at this from kind of a budgetary perspective. So there's lots of different activity happening in states across the board on 988. Melissa?
Thanks, Suzanne. So as we begin to talk about financing for MRSS services, and going back to what Denise said in the beginning, this is a longer slide set than has been presented in the past, but we wanted to leave you with a robust array of resources so that when we're done with this presentation, you would have a rich document that you could use to reference with your state Medicaid agency, with advocates, and with others. So we hope that these terms will help you, help improve your knowledge, and help you speak about this authoritatively with individuals in your state. So as we begin to talk about financing for MRSS services, we're talking about Medicaid, the publicly financed healthcare structure that is a share between the federal government and state governments, where each assumes a portion of the financial responsibility for paying for services. And the way in which states assume that responsibility is through a couple of different authorities or mechanisms. So those are a state plan service, a demonstration waiver in which the state is seeking some innovation in exchange for flexibility with the federal government, administrative claiming, which we're going to speak in more detail about in forthcoming slides, some enhanced match opportunities as a result of the American Rescue Plan Act, where states are able to claim a higher or greater than usual share of funds due to some enhancements, federal block grants, so funds allocated to states through SAMHSA, traditionally under a formula, commercial insurance coverage, so our private insurers like, for example, Aetna, Blue Cross Blue Shield, what many of us get as employer-sponsored health insurance, hospital community benefit dollars, so as a part of the Patient Protection and Affordable Care Act, sometimes called Obamacare. We see that hospitals have to engage in a community engagement process every 3 years, so how they have to spend those dollars, and then state general funds, so the thing that our legislature passes every year or 2 years, depending on the state in which you reside. And details about each of these are going to be provided in subsequent slides, but this is a comprehensive list of the ways in which states are supporting and sustaining the delivery of mobile crisis and response services. Suzanne?
One piece that I think is really important to know as you work to design, implement, and finance mobile response and stabilization services is MRSS in the Medicaid space. Melissa and I are specifically talking about Medicaid right now. You can use a lot of different Medicaid authorities and mechanisms to support and sustain this service, right? And so we often start with being very clear about what the service is that you want covered and who it is for, right? In terms of the populations that you need the service for, or that you want the service for. Here in this case, you know, we're talking about, you know, services for everyone, regardless of insurance, but really trying to leverage that Medicaid piece. And so MRSS components and services can be built into Medicaid state plans. They can be built into the rehabilitation option, the EPSDT option. They can also be part of the various authorities to offer managed care and to use a managed care delivery platform. So all of those mechanisms are available as a tool to sustain MRSS. And as we move through this slide deck, we have, you know, specific state examples as well as links to state language that we will be sharing with you. We also have some states that are rolling in MRSS services into their 1115 demonstration waivers. So unlike a Medicaid state plan where, you know, you may, you know, create or identify a new service and a new service description and a provider type in a state plan, You don't use 1115s for just a single service, right? 1115 demonstration waivers are part of larger scale kind of design or testing or evaluative efforts for the Medicaid authority. But we do have many states, as they have designed those kind of evaluative questions, are including MRSS in what they're trying to expand and offer to Medicaid recipients. So again, as we start with this slide, or as we move through some of the other Medicaid mechanisms, MRSS can be sustained, and you can leverage Medicaid and sustain funding for MRSS through a variety of different mechanisms. And it's also important to know that most states may be using more than one Medicaid mechanism because of the various options they have available. So we'll be also highlighting where you may see something reflected in a state plan. It may be in a Medicaid rehab option. It may be part of an 1115. It may be part of a managed care option. And so they're leveraging multiple kind of different ways in order to sustain that funding. Melissa?
Thanks, Suzanne. So continuing with the discussion, we also wanted to highlight administrative claiming, since there's at least one state example we highlight, Georgia, coming up in a bit, that uses administrative claiming to finance some or all of their MRSS services. Administrative claiming generally provides half of the costs to states associated with, as the slide says, establishing and supporting delivery of these community services. For a bit of context, states, this has been a less popular option because of the burden it places upon states to come up with the administrative claim. So the way in which states have traditionally had to do this is through a time study, and states have had to hire an accounting firm, for example, to validate the number of minutes within a day that individuals who are eligible for claim spend on the provision of this service, and validate it with state Medicaid. It's historically been a complicated process for states to undertake that's burdensome, so not one that we've seen as a popular option historically, but more states are exploring it now because of a letter from the Centers for Medicare and Medicaid Services that we're going to highlight in forthcoming slides. And for additional details, the National Association of State Mental Health Program Directors put out a really excellent document linked here on funding crisis services that includes a list of considerations, questions, supports, when you're thinking about using administrative claiming to draw down some of that federal match. Suzanne?
Great, thank you. So we'll begin to talk about some of the specific state examples here. Each of the slides does link to where you can see further state-specific language. So each of these links back to the source documents. Starting with Arizona, I'll say to start, that all of these examples have the four kind of basic elements that you would want to see in a quality MRSS service, right? You've got the ability to engage in various settings. So across these examples, you'll see the emphasis on providing mobile response where a child is experiencing that, in the home, in the school, somewhere in the community. In all of these examples, you'll see clear response times where you have 45-minute or 60-minute response times to mobilize to that youth and that family's location. The examples that we also highlight talk about the need and the connection for family peer support, both as a position in them, but as part of the stabilization component. And then each of these examples also talks about stabilization, that these are not one-time interventions in a community, but they recognize that children and families experiencing a crisis need something in an ongoing way to identify the supports and ongoing services that they need. And so stabilization is kind of core to each of this. Arizona, starting off at that particular example, using its regional behavioral health authority delivery structure, builds in telephonic response, kind of mobilizing within 60 minutes to a child or a family's location. They also have incentives for the teams to respond within 45 minutes, right? So they have an expectation of within 60 minutes, but they've built in incentives to try to create a faster response time where possible. Arizona also builds in a crisis stabilization component and peer support as part of its service benefit package. Georgia, as we had mentioned before, when Melissa was talking about Medicaid administrative claiming, largely relies on administrative claiming for its mobile response and stabilization component. Georgia is an example where they're also leveraging the rehabilitation option, so the rehab option part of Medicaid, for other aspects of the MRSS continuum. So Georgia is using administrative claiming, say for the mobile response part, but the call center capacity and kind of their on-the-ground crisis center locations, they're leveraging other Medicaid options, the rehab option for those pieces. Georgia also has a specific emphasis on making sure that services can meet the needs of various populations that they want to serve, including youth with autism spectrum disorder. And finally, Minnesota also builds in those 4 kind of key requirements that we talked about: mobilizing to a location, response time, family, peer, and other community supports, and a stabilization component using their state plan amendment. Melissa?
Picking up where Suzanne left off, and just to emphasize, part of the reason we included a fairly lengthy list of states here was so that you all could see the regional variation. So it's not just coastal states that are doing this, or not just traditionally wealthy states, and it includes states that have not yet expanded Medicaid. Georgia is a state that has not expanded Medicaid. But picking up, New York again includes the elements Suzanne mentioned, and not included here, but noteworthy is that New York also has a separate Medicaid crisis stabilization service for children and youth that has to be connected to their MRSS continuum and indeed other behavioral health services. If folks on the call are interested to see the Medicaid language, I'd be happy to pull it for you, and certainly we could include it in follow-up. And then Virginia is an interesting example because they are a state, if you think back to the map that Suzanne covered a few slides ago, that has passed legislation that specifies a telecommunications fee to support the work of MRSS and their call center. They're also a state that is doing quite a lot of work around disparities in response, and published 2 lengthy state reports regarding disparate impact among populations of color and rural populations, particularly in the South and Southwest region. And Virginia actually, in terms of reimbursement as part of their Medicaid funding mechanism, has a rate differential. So they're paying certain regions of the state more because costs are expected to be higher than other regions of the state. Suzanne?
Thank you. Hazelyn opened for us with the importance of engaging families and youth. And specifically what we have highlighted here for you is including family peers and opportunities for youth peers as part of the benefit itself, right? So oftentimes we think about the family voice or the youth voice as only advocating or only giving input to. But here, in addition to that important role, here what we're emphasizing is best practice examples from several states where peers, where family peers and youth peers are providers as part of a team supporting youth and families who are utilizing the MRSS service. So Kentucky requires that certified peers, including youth, are part of its residential crisis stabilization program. So specifically here, for those youth who may be receiving some type of crisis stabilization service, the peer component is part of that crisis stabilization service. In Massachusetts, we have an example where family partners, using the Massachusetts language, are part of the core staffing required of the emergency services provider. In Massachusetts, the emergency services program is kind of a large umbrella that has multiple components, including their mobile crisis intervention, their language for MRSS. And so within that kind of broader umbrella of emergency services, family partners, family peers are required to be part of that service. And those ESP providers may be using them as part of kind of transfers for kind of continued support telephonically. If somebody calls in, they may be used as part of the stabilization support for a family and a youth in crisis, supporting, offering those stabilization services and connecting them to ongoing supports. Likewise, New York also includes family peer support individuals, here called credentialed family peer advocates, as part of their multidisciplinary team. And in recognition of the needs for substance use support and treatment, also credentialed alcoholism and substance abuse counselors. And finally, as Melissa just mentioned about Virginia, Virginia also includes their family support partners in both their crisis intervention and their crisis stabilization kind of service definition as part of that benefit. Melissa?
So we wanted to highlight some recent Medicaid developments that present significant opportunities for states thinking about starting to cover MRSS and related services as part of their Medicaid benefit, or expand what they cover now. And so on the left, and please don't feel pressure to read this because we know it's teeny tiny, but I wanted to pull the section of law so that you could see it, and likewise the letter from the Centers for Medicare and Medicaid Services on the right, the language from the American Rescue Plan Act, and the letter that came at the tail end of 2021 regarding Medicaid guidance. And Suzanne's going to emphasize this in the next slide, but I'll begin, which is that the American Rescue Plan Act included a section for states to create a qualifying mobile crisis intervention services with an interdisciplinary team. And as part of a way to incent states to do that work, they raised the match rate. So I'm in Maryland today. That's where the University of Maryland is located. And our Medicaid match for most services in the state is a 50-50 split. The state pays 50 cents and the federal government pays 50 cents toward each dollar cost of services. It's an equal share. If a state has traditionally been more economically disadvantaged, the federal match rate is higher. So Mississippi currently has the highest federal share and the state pays a lower share. If you have questions about that or need help, please let us know. We'll be happy to go into some more detail. But as a way to incent the provision of MRSS services, the American Rescue Plan Act increased that match rate to 85%. So in Maryland, that's 35% more than we normally get. And then as a follow-on, after the Rescue Plan Act passed, the Centers for Medicare and Medicaid Services released a state health official letter with formal guidance to providers. And Suzanne is going to talk more about each in the next slide.
So as Melissa mentioned, we have this opportunity and this incentive around these additional ARPA funds. And this allows Medicaid over a period of time to receive an increase in match. Melissa, you just mentioned the kind of specifics around it in terms of the numbers and things like that. So I don't have too much more to add other than, you know, kind of highlighting from an advocacy or a planning perspective, to be thinking both about when you're designing this, be thinking about those kind of time frames in which these funds are available, and to be thinking about the ways to maximize the drawdown for your startup, right? So that you want to be able to maximize the dollars that you could draw down for your state by ensuring that your readiness for implementation out the gate is going to be able to draw down a higher amount of money for you. From kind of a planning perspective, it's going to be really important to know kind of where your state is at in terms of consideration of leveraging this opportunity and kind of being part of the support and kind of influencing the implementation plan around this. Those are kind of the key take homes we would encourage all of you to have. Next slide.
So again, to qualify for the enhanced match, that 85%, there are some things that the federal government requires of states. So they have to provide screening and assessment. They have to provide stabilization and de-escalation services. They have to provide coordination and referral to other kinds of supports and services for the population to be served. The team must be multidisciplinary, and in the law, you'll see that they did include an explicit mention that that multidisciplinary team could include peers, and it must include at least one professional who can conduct an assessment under their scope of practice or their licensure relevant to state law. So that'll vary depending on which state in which you reside and your boards of practice. The teams have to be available 24/7. They have to be trained in trauma-informed care and harm reduction, because we're thinking about responding to individuals with substance use disorder and co-occurring needs as well. And they have to respond in a timely manner. And the specific guidance, again, is provided in that late December 2021 letter from CMS to state health officials to consider the ways in which you can meet, for example, the definition of multidisciplinary, the role of telehealth in providing and responding to crises, particularly in rural or long distance areas and areas with poor access to mental health professionals or health professional shortage areas, and some details about trauma-informed care.
Thank you. And I appreciate seeing in the chat other examples that are coming forward. Amy, highlighting from Indiana, has a similar mandate around family peers. So thank you very much. We definitely want to be able to highlight those things during our Q&A. We've been talking a lot about Medicaid, and now we're going to switch to the Substance Abuse and Mental Health Services Administration block grants. So as most all of you are aware, the SAMHSA block grants are formulary grants to the states to support various activities. And kind of when you think about kind of SAMHSA's stated goals around the use of the block grants, it's to ensure that states have dollars available to improve the health of everyone, to ensure that everyone has a stable home, to ensure that everybody's kind of connected to a purpose in their life and that it has meaning, and that they're connected to a community. And so, you know, those are kind of the basic tenets of what SAMHSA is trying to achieve through its block grants. And so, you know, block grants are kind of a very important component to sustaining MRSS, because they allow states to kind of test out a new model. And often what we have seen is that states are leveraging their block grant dollars to be able to demonstrate the effectiveness of MRSS And then, you know, engaging in dialogue with their Medicaid partners to say, hey, look what we've looked here. Look at what this has been able to achieve through the block grant. This is the broader impact we could have by using kind of a Medicaid sustainable funding, right? Or being able to go to commercial insurers with that same information. Here's how we can sustain it. So the block grants serve a very important role to being able to, in this case, support the gathering of information around the effectiveness of MRSS, certainly around being able to demonstrate certain aspects of a model, particularly for those states who are rural or frontier, and you're grappling with a different set of response time issues or use of technology issues that you may have in those particular jurisdictions. It can also be used to kind of support broader kind of system infrastructure for those who are uninsured or who are underinsured. When we think about designing an MRSS system, we, you know, the most effective systems have to be universal in nature, right? We can't be thinking about these selective entry points only for Medicaid recipients or commercial insurers. And so in these MRSS services, we need to be thinking about how do we ensure that somebody has access to a service regardless of funding source that may be attached to them from an insurance perspective. Also, these dollars allow you to collect information, evaluate, and look at outcome data to be able to both demonstrate your effectiveness, as I just mentioned, but from a quality perspective, kind of continue to improve and refine what you're learning and what you're doing and the impact that you're having on children and families. Next slide, please.
We wanted to provide an example of the ways in which SAMHSA also directs states with block grant funding. So if the federal government has an initiative or purpose that they themselves are interested in, they can set aside a portion of the federal block grant that is directed to states for specific purposes. And here, the FY21 mental health block grant included a 5% set aside, so 5% of the amount directed to states to examine crisis care programs that would address the needs of individuals with serious mental illness and children with serious mental and emotional disturbances. And again, as Suzanne said, these funds are really central to help states do some things that Medicaid can't reimburse for. So as states are thinking about purchasing technology to set up these systems, how to do triage, how to evaluate for suicide risk, which assessment tool they might purchase and use, a lot of the planning pieces that are not coverable by Medicaid because they're not directed at a specific person are able to be covered through the use of block grant funds. So block grant funds are really central to help states plan for and begin building their crisis response systems as they get ready for things like taking advantage of the enhanced federal match that's now available through ARPA. Next slide.
So let's turn to commercial insurance. We've talked about 988 specific legislation. We've talked about Medicaid. We've talked about block grants. And now as we think about creating an MRSS system that can serve everyone in a jurisdiction, we wanted to mention commercial insurance. And here there's a few different things for us to be raising and highlighting as opportunities for you all to consider, whether it is something that you specifically are responsible for in your state in developing, or advocating for its inclusion or advocating for its consideration. So through the Affordable Care Act, we have a mandatory requirement of essential health benefits that applies to certain health plans, right? And so there are 10 categories of what is considered essential that has to be part of those plans' health benefits. and that includes both emergency services as well as mental health and substance use services. Now, each state can decide what it considers to be its essential health benefits, right? And each state can decide what has to be included as part of that package within those broad 10 categories. And so there is an opportunity for specific consideration of mobile response and stabilization to be specifically covered. We have broad general coverage of emergency services. We have broad general coverage of mental health services. But we all know here that mobile response and stabilization is unique. It has some unique tenets attached to it, and it is different than what had been operated traditionally from kind of a behavioral health crisis response system, which was more historically geared towards level of care assessments for a hospital need. And so specifically calling this out, the MRSS in the essential health benefit package is an opportunity to ensure its availability in your particular jurisdiction. Another added component to this is the Mental Health Parity and Addictions Equity Act. Now, MAPIA doesn't directly require coverage of any specific benefit, but what it does do is that if a plan covers mental health and substance use, it has to offer mental health and substance abuse benefits, substance use disorder benefits in a way equivalent to the medical surgical benefits. And the equivalency has to do with three things: annual and lifetime limits, financial requirements, and treatment limits. Now, immediately on the face of it, it can be difficult or maybe a little bit more challenging to see where MRSS would fall in that. But we do know that there have been instances where, say, number of kind of visits to an ED or challenges around access to kind of a crisis service may not have been provided on par to the same physical health emergency services that are available. So again, we raise it as a consideration in a state's MAPIA work and for advocates in kind of their MAPIA work around specific inclusion of MRSS. And finally, as we think about MRSS, we have kind of mandates that commercial insurances specifically cover it. And here we have highlighted Massachusetts for you, which back in 2018 enacted legislation requiring commercial insurers to specifically cover their mobile crisis intervention. Again, Massachusetts specific language for MRSS. It was part of a suite of other requirements for a broader array of home and community-based services for children in that state. Commercial insurers were also required to cover a variety of other services, including intensive care coordination with wraparound. But here we see that mandate on commercial insurances to include it, moving Massachusetts towards their ability to have kind of universal coverage in their mobile response continuum. Melissa, next slide, please.
Sure, and I'll note just quickly for the Massachusetts example that it's state regulated plans only, so not self-insured plans, which are some kinds of plans that particularly large employers sometimes have. So Massachusetts as a state doesn't have the ability under federal statute to regulate those other health plans. So it's not every health plan, but if you think about each addition covering more children and families, Massachusetts passed this law to cover a larger array of services for a larger group of children and families. Under the auspices of the authority that it had. So it did what it could as a state. Moving on to hospital community benefit dollars. So again, the Patient Protection and Affordable Care Act required as part of this this enormous piece of legislation that passed that all nonprofit hospitals, so tax exempt hospitals, conduct a community health needs assessment every 3 years. So they have to bring in community members to the table. They have to develop an implementation strategy based on identified health needs. So in one community, that might be an asthma initiative. In another community, it might be behavioral health crisis services. In other communities, it could be an aging in place program to prevent falls. The idea behind this was who is showing up at the hospital, ED, and for inpatient care and other kinds of acute care services that shouldn't be, or that we could ameliorate those health conditions in another form or function. Could we do falls prevention? Could we have behavioral health crisis intervention? Could we have an early childhood program? And those hospitals are required to report on their efforts annually to the Internal Revenue Service. Now, in fairness, it's a pretty small piece of their annual budget, generally about 1%. And in lots of states, including here in my home state in Maryland, those benefits have often been what are called in-kind services. So the hospital says, we're going to provide a service to you, the community, rather than dollars. But that isn't always the case. Here in the greater Baltimore region, GBRICS, the Greater Baltimore Regional Integrated Crisis System, is spending $45 million, some from local jurisdictions and some from this community benefit dollar pool, to transform behavioral crisis response in the central Maryland region. And I've listed Baltimore City and the surrounding counties as part of that central Maryland region to enhance the delivery system that we have now, which does not respond 24 hours a day, is not available within 60 minutes all the time, to begin making those enhancements that are needed to respond to children and families round the clock. Those $45 million are partially coming from some of that hospital investment as a result of that community health assessment that revealed there were a significant number of adults and children and families accruing to emergency departments here in the central Maryland region where they were not well served and could be better served in the home and community by trained MRSS providers. Suzanne?
Great. And finally, before we move to highlighting some additional resources for you, the last financing strategy that we wanted to talk about was general revenue. And as we all know, general revenue is part of everyone's efforts around MRSS, right? Whether it's contributing to infrastructure dollars, whether it's contributing to evaluation, aspects of training, all of the states have leveraged general revenue at some point in their process or in an ongoing way. As you think through kind of what are all the levers that you can use in your state to sustain MRSS, it's important to consider that general revenue, while very flexible and kind of available, is also the first dollars that can be gone during times of fiscal crisis. Those are often the first dollars that may be reallocated elsewhere during times of need. So while they are dollars that we do rely on and we think about, we are encouraging everyone to be considering bringing together multiple mechanisms to support their financing strategies and not rely solely on general revenue, not rely heavily on general revenue as part of your sustainability process. It does allow you to be considering some mechanisms for populations of folks who are uninsured or who are underinsured. It does allow you to be considering kind of certain startup costs that you can't otherwise receive match for. It does kind of support communication and community-based strategies to ensure that you're really embedding MRSS in communities. It can be an additional support from an administrative dollar perspective if you've already reached your Medicaid admin cap, and so claiming that those Medicaid pieces aren't available. And it can also further support kind of use of value-based strategies or other shared savings incentive strategies, particularly as part of kind of broader efforts that you may have. So again, recognizing that general revenue is part of the multiple levers that are needed to sustain MRSS. We're really encouraging consideration that it be used strategically, it not be relied on as its sole source, and that you use any general revenue funding time to be really thinking about some of the other sustainable solutions that we've highlighted for you today. And finally, I'll turn it back over to Melissa to highlight a few resources that we've pulled together.
Thanks, Suzanne. So as always, we wanted to highlight the Institute's resources on mobile crisis and stabilization. So they're collected on a single page linked to here. The Center for Law and Social Policy's Youth Mobile Response paper that talked about mobile response and stabilization services as an investment in decreasing the number of youth who are involved with juvenile justice, and for youth of transition age, perhaps the adult justice system. Crisis Now hosts a Wednesday crisis jam. So it's kind of I don't think it would insult anyone to say freewheeling, but very informative Wednesday chat over a lunch hour. And those are recorded and you can access them on their website. And they have an excellent library of resources from a number of states that have joined the Crisis Jam to highlight efforts and initiatives in their own state around service expansion, telehealth, value-based payment. If you can think of it, they probably have had someone talk about it at some point. And then NASHPIT's technical assistance paper. So the 2018 paper on making the case for a comprehensive children's crisis continuum, which includes examples from sort of states leading in this area like Connecticut and New Jersey, including some of the evidence base that they have managed to accrue in terms of declines in emergency department use and cost savings there. Then improving the child and adolescent crisis system as we shift from 911 to 988. And finally, again, the funding opportunities paper that was highlighted earlier is quite a dense but incredibly useful document, again, expanding upon different Medicaid authorities, including administrative claiming with examples from other states and federal statutes included, so that you and your state and family and youth partners can be thinking about ways in which various Medicaid authorities might work for you and your state. And with that, our contact information.
Great, thank you. So let's take down the slides and have a discussion. Hazel, I want to turn to you first. And you're great at reflecting back for us on what you've heard. And if you don't mind also weaving in ways that parent and youth voice can be used to support the quality design, the financing, and overall quality systems.
Thank you so much, Denise. First, I want to especially thank Melissa and Suzanne for their wonderful presentation, rich with information about different models and how we are moving forward with mobile response and stabilization services across the country. I was particularly interested to hear of how some of the different mechanisms work and can work together. Coming from a healthcare perspective, the inclusion of community benefit dollars that hospitals have access to me, that was a perfect place to think about where, on a local level, youth and families can get involved, because they're already familiar with many of these facilities. They've used them. They're embedded in the communities that we serve. And so hearing about the different places where our voices can be heard sparked an interest in exploring what exactly is the mechanism for getting us into those places. And the community health assessments that have to be done every 3 years, I think, is a wonderful opportunity for us to explore. I know certainly in our community, through the Children's Interagency Coordinating Councils, there's always an opportunity for youth and family input around service priorities, around evaluating how the services are working. And I would think that those opportunities exist pretty much nationwide. So thank you for mentioning that specific opportunity in terms of the community health assessments and the role that hospitals play in that. As I was listening to the presentation, I was thinking about the different places where youth and family voice can really play an important role. And for me, it comes down to not only plan design and the services that are being offered, but evaluation and then ongoing participation in the conversations, as opposed to episodic contact with families saying, we need to do this for a funding opportunity and we have to submit it by this date. But what are the ways in which we can have ongoing dialogue with families? And the concept of periodic meetings or listening sessions where families can give input on a local level and on a state level, I think is something that we've found helpful here in New Jersey through our contracted system administrator, through our children's interagency coordinating councils, and even through our providers, such as the family-run organizations, creating opportunities for families and youth to express how the services are working, how it's impacting them, what the financing decisions are being made, that, how that's impacting their experience. I would like to just also mention that it's important for us when we think about advocacy and involving youth and family voice, it's important to think about how families get prepared for that, right? It's not an automatic thing, and not all families are the same. Some families come from professional backgrounds, or youth come from backgrounds where they may have had specialized training and opportunities to meet with elected officials, but just to level the playing field and recognize that some of our less knowledgeable, let's say, families, or families that may not have been traditionally engaged for whatever reasons, we need to have mechanisms for educating them and preparing them for advocacy. And one of the things that we highly recommend, and we do here, is to have a step-by-step guide for families on how to advocate. We created a toolkit that makes it easy for families of all types to understand and is linguistically accessible for those that speak other languages, primarily in our market, it's English, Spanish, Portuguese, and French Creole, Haitian Creole. So we created a toolkit that was easy to understand and that made it possible for them to know who to contact, what role that individual plays in the decision that's going to be made, the financing decision that's going to be made, and also to think about who else can we engage, who are the allies that we can engage. Because oftentimes we as families may feel like, I don't know this person, and I don't feel comfortable approaching this topic, but we can always look to who are the allies, people that we know who are in a position to support what we're advocating for, and that we can engage so that we don't do this alone. One of our mantras is, you don't have to do this alone, we're here for you. So we tell families that, and we want that to be a reality, whether it's in the one-to-one work that we do or the systemic work that we do. Another important point with families is coaching and training them to understand and to define their single overriding communication objective. What is the message that you have, the key message that you want to communicate to the audience? Because you have about this much time to really capture their attention and to be heard. So what is that single overriding communication objective? And framing that in a way that it gets them to, this is the situation, this is the action we'd like you to take, and this is the result that we're looking for. Another point would be the inclusion of lived experience to demonstrate how impactful these services are. I don't think that can be, the importance of that can be understated, but how to do that in a way that's respectful and well-boundaried. So that's, those were some of my thoughts as I listened to today. and educating families on the current status of financing in their state, because oftentimes they don't know. They're asked to give input, but they may not necessarily have sufficient working knowledge of how things are currently structured in finance to really be able to give input. So in summary, it would be, what do they need to know? Telling families, preparing families, what do they need to know? Who do they need to know and hold accountable? And how do they go about doing that? And I think accountability happens on multiple levels. It happens locally, it happens in state conversations, and it happens all the way up to the governor's office in states where there's room for families to give input through their elected officials on the decisions that are being made around financing and service delivery.
Yeah.
Did I answer your question?
You absolutely did. And what was striking to me is everything you were saying is not just applicable to family leaders, it's really applicable to all agency and state and local leaders in trying to figure out all the different financing and puzzle pieces. So along those lines, Melissa, I'm going to ask you, this is overwhelming. Thank goodness you had all those wonderful slides. The chat box was asking for them, right? But what's my go-tos? What should I have prepared when I want to go approach my Medicaid state authority?
Sure. So I think critical to developing those relationships with the Medicaid authority in your state is bringing your experience and the evidentiary base behind mobile response and stabilization. So it is always helpful to approach Medicaid with why the service is good and important, because one of the things that they're going to immediately be thinking about is the budgetary impact for the service. Every state that adds something to their Medicaid state plan or their waiver has to come up with dollars to support that service. So why should they consider adding this as a service? So here we can talk about the enhanced match rate. We can talk about return on investment for mobile response and stabilization. And then I would encourage you to bring some examples, and the slides have them, of other states that have successfully implemented mobile response and stabilization in the kinds of communities, in the kinds of ways that you in your state think are appropriate, having gone to the table with your family and youth advocates to make sure that the service you're designing meets the needs of individuals and families. So in other places that have been successful, how have they done that? How have they designed the rate? And what challenges have they faced in getting their state plan or waiver approved? And what challenges have they faced in designing a workforce around providing the mobile response and stabilization services? Medicaid typically likes to know successes, what other successes have states had with things, particularly states that are in the same CMS region as they are, as they're thinking about approval processes. Suzanne, anything to add there?
That was a great list, Melissa. The piece I would add is, since at least 1981, when the block grant kind of formulation that we have now was in existence, we've had, some type of crisis response system in states. The piece that we're contending with right now is being able to be very clear about how MRSS is different from what states have had traditionally. And so I think that's a key piece to be able to be prepared to discuss with your Medicaid authority. Why MRSS is different and why that difference is important to the outcomes for children and families that Medicaid authority wants to achieve.
That's a great point. And that's why this whole series taken together is really a fabulous tool for state leaders. So I heard Melissa, knowledge, right, and examples. Suzanne, when you were talking about Medicaid state plans, you mentioned the rehab option and EPSDT option. Can you just describe what those are? And I will pop in the box what EPSDT stands for.
Sure. So within Medicaid state plan, there are various ways that a Medicaid authority can cover different services and ensure service availability to different populations. And there are lots of those within kind of a Medicaid state plan. So EPSDT, which Denise is popping into the box, early and periodic diagnosis, services, and treatment, screening and treatment, is kind of one component that ensures coverage of certain types of physical health and behavioral health services for persons under 21, right? And so that's kind of one mechanism states use to cover certain services. Another mechanism that states use is a rehab option service. And so within rehab option, that allows states greater flexibility to offer kind of home and community-based services and other support services to persons experiencing some type of SMI or SED, so serious mental illness or serious emotional disturbance. Again, what I always like to highlight is I would really encourage folks not to begin a discussion, and Melissa, kind of talked about things to raise when talking about MRSS. I think it's important not to begin a discussion with Medicaid authorities. You need this waiver or you need this state plan, right? Because there are lots of different ways to sustain MRSS funding, right? And so considerations of where to put it in a state plan, how to cover it, what authorities to use is not kind of a starting point for a discussion. Being very clear about what is the service you want, who is it for, and then thinking through what are the types of providers that really need to be credentialed or that will have the appropriate skills to deliver it. Those types of things lead to the decision and the discussions about what kind of Medicaid authority to use. And again, as we've highlighted in those examples, oftentimes you want to use more than one because certain aspects of the MRSS continuum are going to be more easily covered, or you could use certain types of state plans or certain types of authorities differently to kind of fulfill that graphic that we had on that initial slide. So as a starting point, and we can also, I think, drop in some additional resources as part of kind of where to get some additional information about each of the specifics. Each kind of state plan or waiver has upsides and downsides to it, right? No one is perfect for everything you're trying to achieve, but we can certainly provide some additional information as you look at your state or your county's context. You can be considering, oh, this is how this upside will play out here, or this is how this kind of downside could play out here, and how do we mitigate it?
So taken together from what Melissa and you have said, we really want to convey to Medicaid authorities the why or the what, right? And the why and the who it's for and who will be providing the service, and then work with them as to the how.
Yep.
What's that Medicaid mechanism?
That's correct.
So going back to the chat box, Heather did ask, are there any rules from Medicaid which explicitly prevent reimbursement for co-responder teams which include law enforcement?
So
That you know of.
We can either one.
To the best of my knowledge, there is not an explicit rule against co-responder teams. That said, law enforcement officials are traditionally not part of a provider type that could be reimbursed by Medicaid. And I would note that the state health official letter that came out in December strongly discourages the use of law enforcement as part of the response team. And it includes language like creating these mobile response and stabilization teams to serve people instead of law enforcement, rather than law enforcement, avoiding the use of law enforcement, except where necessary. So recognizing that states and localities have flexibility to design the MRSS benefit, as Suzanne noted, and we noted through the slide set. The line from CMS in the state health official letter envisions a design that includes a multidisciplinary team without law enforcement.
That's right. And I would definitely, reinforce that. I would take that question back. Before you think about the funding aspect of it, what is it you're trying to achieve by a law enforcement presence? And does that make sense as part of a mobile response approach? Or is it about connecting to another appropriate service or support in a community, including kind of accessing those types of emergency services in certain scenarios, right? So, law enforcement is not necessarily, conducting a health service, right? They're not necessarily, as Melissa said, a provider type. But it is important to be very specific about how you link to them, when you would expect to, and when you wouldn't expect to, right? Because we don't want to unnecessarily escalate situations that can be appropriately dealt with within a behavioral health intervention perspective. But we also recognize, and I think Georgia and the links we provided in Georgia are a great example of this. They've tried to be very specific about when they would consider law enforcement engagement at different stages of a mobile response intervention, particularly when, supporting adults. So I do think it's about being very deliberate in when they would be engaged and why, and when wouldn't they be engaged, and being very clear on them.
And to Suzanne's point, that the state health officials letter also includes the need to develop those protocols with law enforcement to respond to crises. And with CCBHCs, the Certified Community Behavioral Health Clinics, to be clear on whose role and responsibility it is to respond in a crisis, and depending on the triage and safety needs, but those protocols should be in place. And I popped in the chat just quick a portion of the CMS state health officials letter, so you could see the actual language that was included.
Thank you for that. And I know we also spoke about law enforcement in our, I was going to say episode, but why not episode, our webinar on someone to respond. So I refer you back to that as well. Melissa, this question also came up while you were presenting and talking about the 85% enhancement. So throw it out to you and to Suzanne, and then Hazel and I do want to get back to you too. So does the MRSS team have to have at least one person respond in person, or does telehealth response qualify to receive that 85% enhancement? Does the letter speak specifically to that?
So the letter strongly implies that there should be a person responding to the individual and family experiencing a crisis. However, telehealth is included as part of the 85% match in states, and the letter specifically notes that it can be used as part of the screening and assessment process, or the stabilization piece, as a connection to other home and community-based services, and as follow-up to the initial crisis. The multidisciplinary team is, I think, a really important piece here in states that are experiencing behavioral health care shortages, and that's most places at this point. The use of telehealth as an extension to have, say, a licensed person who under the state law has to supervise an assessment or has to supervise unlicensed individuals can be provided through telehealth to try to stretch and sustain those scarce resources where you're sending out peers or bachelor's or master's trained individuals to the on-site response, and then using telehealth as an adjunct or an enhancement to that service. So while it's not explicit in the letter that a telehealth only response is prohibited, the tenor certainly suggests that a community-based response is preferable.
But so one in person plus and telehealth.
Yes, it certainly can be part of the multidisciplinary team. And again, there's explicit language in there about someone responding in person and someone else being available through an iPad or phone or audiovisual equipment. Sort of take your pick depending on what telecommunications resources look like in the community where you live. But yes, that telehealth is explicitly part of the initial and ongoing response service.
Great, thank you.
Two things I would add to that is it's important in your use of an authority and your use of that to be very transparent in your language about what you include and what you don't include. So this is not a time to obfuscate and kind of not be clear about it, right? I think the other piece is in that clarity to be clear why you're doing it, right? So again, I talked earlier about rural and frontier states wanting a response time that makes sense for the large area they're covering, perhaps using bachelor's or master's trained people who may be more local in a community, and then using somebody who's licensed to be kind of their kind of a responder who may be in a more centralized place. Kind of the clarity around that workforce piece, what you're trying to do, and the other goals you're trying to achieve by using telehealth approaches is really key.
And not to belabor the point, but just finally, one other thing from the CMS letter to both Suzanne and Hazelyn's point is they specifically call out the cultural and linguistic competency piece, including for individuals who are deaf or hard of hearing. So telehealth as a way to provide those language access issues or ASL accessibility with members of the community is critically important to making sure we can serve all people with need.
Thank you for that. And so those of us who are watching a recording and can't see the chat box, Hazelyn also noted during the beginning of our discussion about the need to educate law enforcement about crisis response protocols for when they are called and responding. Hazelyn, we also had a slide specifically about peers on teams. Can you talk a little bit about your experience in New Jersey as to what do the teams look like in New Jersey?
At the present time, there are a few family-run organizations that actually have been doing work with mobile response and stabilization as part of the team. How that looks may vary in the different communities. I certainly think it's a model that's worthy of further exploration, particularly in our rural communities where there's tends to be some workforce issues and lack of access. So the richer the teams can be by providing opportunities for peer support, the better. That peer support can begin with mobile response and continue as the youth and family may progress on to the higher levels of care through to the care management organization, etc. Typically, a family would have to wait in those counties where we don't have those mobile response contracts. They would have to wait until they are actually enrolled in the CMO to benefit from one-to-one peer support. And that we find ways to deal with that because we make sure that families in our community know through our outreach to schools, our outreach to faith-based organizations and other providers that all families can access what we call the warm line. Can access the warm line for information and referrals. They can also participate in all of our support groups, educational sessions, and workshops. So, those are some of the ways that we currently are structured. Having said that, I do believe that there's a great benefit to having one-to-one peer support available at the mobile response level, because I think it can also serve as a way of maybe bringing stabilization to the family so that they don't have to necessarily escalate to the highest level of care. And I think that can be very beneficial and also culturally responsive, because many families will be apprehensive about continued services through the health system but they may be more receptive to the involvement with peer support. And peer support providers, such as our family partners, are uniquely skilled in communicating to the families and explaining the experience that they would have and lowering sometimes the resistance that professionals may experience. So I think it's an ideal partnership and a great opportunity to further expand the support we provide to families.
Mm-hmm. Denise, you're on mute.
Well, thank you. I would have just kept talking. Melissa, when you were presenting, you talked about, you used Georgia as an example of a state that had not expanded Medicaid. Can you explain what that means?
Sure. So the Patient Protection and Affordable Care Act, the ACA, Obamacare, sort of take your pick for names, initially required states to expand Medicaid. Then there was a Supreme Court decision that gave states the flexibility rather than required them to expand Medicaid. So historically, Medicaid has been a program that, to a large degree, serves parents with dependents and children, and then some aged and disabled folks who are also impoverished. So as states have had that criteria, it has traditionally been a fairly narrow range of individuals who are covered under Medicaid. And you needed a fairly low income, particularly as a childless adult, to be able to get coverage as a Medicaid beneficiary in a state. And indeed, some states did not offer Medicaid coverage to any childless adults at all. So after the Affordable Care Act passed and the Supreme Court weighed in, states were given the option to expand Medicaid to all residents of the state who earned at or below 133% of federal poverty. So some states like Maryland already had an expansion. We had something called the Primary Adult Care Program that offered a limited benefit to adults with lower incomes, but after the Supreme Court decision, Maryland made the decision to expand Medicaid to all lower income individuals, regardless of whether or not they had dependents. But again, that's a state decision. So Georgia is a state that has opted not to expand Medicaid to all individuals earning 33% of up to 133% of federal poverty or less. And again, that's a state decision. Some have opted in, some have opted out. So when we talk about states that have expanded a benefit, they are covering more lives as part of their Medicaid program than they were before the Affordable Care Act. I hope that helps.
Does. And Wendy's on the line. I don't know if she's still here, but Wendy Tigreen is one of our participants. So if you have additional information, Wendy, that you want to pop in the chat or unmute, you're welcome to do that. I'm just seeing I got a new message.
I wanted to emphasize that depending on Medicaid, who is covered in Medicaid, this goes back to kind of the point we've been talking about in the webinar, is your use of all of those other levers or mechanisms is going to come into play, right? Mm-hmm. So if your Medicaid benefit covers more individuals in your particular state, right, then you can be thinking about those other financing levers slightly differently than in a state that may not be covering as many populations or individuals through the Medicaid benefit. So the weight of those other options, how you use them, is going to be different because of that.
And when you're, I was just going to say quickly, and when you're thinking, and part of the reason I mentioned it was as you're thinking about that continuum for youth of transition age after 21, when they're no longer covered by the EPSDT benefit that Suzanne mentioned, and you're thinking about how to serve those folks longer term, again, with that diverse use of funds from Medicaid to state revenue funds to community benefit dollars, it might be that it's easier to cover as a Medicaid reimbursable service for children under 21 in your state, and then your youth of transition age would be covered using other dollar sources because more of them aren't eligible for Medicaid in your particular state.
Great, thank you. And I'm just going to read what Wendy popped in the chat box for those that are watching this recording. Melissa offered a nice explanation. It does mean that we have to be mindful, as Suzanne is stating, of the varieties of the health insurance coverage or lack thereof, and which is the best pathway to use Medicaid as a fund source. So thank you. We had a question, I think it's more a contracting question, and we can bring this back to Liz when she returns. So Christine asked if we'll share how 45-minute response is incentivized. I'm not sure that's specifically a financing mechanism, but I just wanted to throw it out to see if any of you had any response to that one.
Mhm.
So Suzanne mentioned it in Arizona, but traditionally, and with the short time remaining, as states have the ability to set Medicaid rates, particularly for managed care, they can incent some practices by offering an additional payment or a small bolus of money for meeting certain quality or outcome measures each year to companies that are providing services. How exactly that works is very dependent on the financing structure, the providers, the contract with your managed care companies. There are a lot of particulars and vagaries involved in that. But that is traditionally how states have incented certain outcome measures, is by offering some sort of pay for performance, where they're either getting a reward for doing something great, or there's a small take back if you don't meet certain kinds of quality measures, or a combination of the two. So I hope that's helpful in the time we have remaining.
I think it is. We have a series of questions from Celia specific to Maryland that we can address through actually Maryland's Learning Collaborative. And I'm wondering if anyone has any suggestions on financing mechanisms to help address hospital overstays.
And by hospital overstays, does that mean not medically necessary, or the lack of home and community-based service availability? Because hospital overstays result from a variety of different reasons, particularly for children, youth, and young adults, right? They can be because a child may not have a family home to return to, right? And so you have a disposition, location, setting that isn't available for the developmental needs of those children. You have the unfortunate circumstance that, you know, a particular set of home and community-based benefits may not be available to support a child, or as we kind of deal with kind of shortages in behavioral health, whether from workforce or services, that there are waits for certain services. And so oftentimes there's consideration of, should a child remain here in this hospital setting until those services can be brought together. I think a key piece to be thinking about is kind of the use of some type of intensive care coordination, using wraparound as kind of a key piece to be pulling all of those things together, and to be supporting both the child or youth, a young adult, the family, and those natural supports and formal supports, to be considering what can we creatively do to support this particular child. We know that those types of processes with those care plan teams can facilitate solutions to a child having to remain in kind of an overstay hospital kind of setting.
Thank you. I also want to thank Amy. She did pop in the chat box the link to Indiana's legislation. We're going to have to add that to our resources. I want to thank all of you. We just have 2 minutes to close out. Do any of you have any final comments, well wishes, pointers? Hazelyn?
So I think this has been a really rich conversation. Pointers in terms of engaging youth and families, often and frequent contact.
Love it. Suzanne?
Be very clear on how MRSS is different and why it needs to be protected with a specific service definition a specific set of providers and specific quality indicators.
Great. Melissa, bring us home.
Don't be afraid. Medicaid is a really complicated, sprawling, highly technical field. And I know it's easy to be intimidated by all of the rules and regulations and authorities, and you think you'll never ever learn it. Try to embrace it as a learning process and a partnership with your state funders rather than something to be feared and a roadblock to expanding and sustaining coverage in your state or locality.
Thank you. Well said. Thank you, everyone, for joining. I promise you, Liz Manley will be back with you next month. Please stay on and take our evaluation. Give us your feedback. It's very important to us. Stay safe and healthy. Thanks all.
Thank you for joining this month's Mobile Response and Stabilization Services Learning Community session. Please take a few moments to complete the evaluation for this session using the following link being posted in the chat. We will be providing a certificate of attendance after completion of each session being offered throughout the entire series. So make sure that you are registered with the same name logged into each session so that we can confirm your attendance and the total time you were a part of this session. Please allow up to 10 business days for your certificate of attendance to become available in Ideas at the Institute. Any presentations, resources, and recordings will be made available to you within Ideas at the Institute. Once you are registered for the learning community, you will have access to all of the upcoming and previously recorded sessions. We hope you join us again for next month's session. You can access the Zoom link for each session and download a calendar appointment for that session by logging into Ideas at the Institute. Access the MRSS Learning Community curriculum and click the View button for that upcoming session. Thank you for joining us, and we look forward to seeing you at the next Learning Community session.